So we're moving into a new chapter now, talking about kidney pathophysiology. A little bit of good news is you can apply a lot of your physiology knowledge from last semester. At least good news from some people's perspective, I suppose. Good old kidney. So let's start right with the congenital disorders, and we'll just kind of move through those. The first one being a horseshoe kidney. Conjoined kidneys, usually joined there at the lower pole. That's the most common one of all kidney disorders, congenital kidney malformations. Sometimes can get caught on the inferior mesenteric artery on its ascent up, and that's kind of a problem. I'm not sure why I have this written down, hepatorenal syndrome. We talked about that last class period. I'm not sure of the relevance right there, but that's okay. Any questions on horseshoe kidneys? Yeah. You know, if it's attached to a vessel and it's causing problems, then it could be worked on surgically. But if it's actually not causing clinical manifestations, symptoms, then okay. I know, just a weird kidney in your abdomen, absolutely. Another disease here, polycystic kidney disease, is the next one on our list. I remember, I think it was a couple years ago for our cadavers. One of our cadavers had just a huge number of cysts on the kidney. Now, cysts on the kidney that by themselves are not uncommon. This is where there is a ton of cysts on the kidney. Okay, individual cysts are not uncommon at all. Actually, very common. The clinical consequence here, it's often genetic and can present with the Potter sequence. Do you guys know about the Potter sequence? Did he bring that up? That's the malformations that can result of the oligohydramnios. So you remember the polyhydramnios, what was that? Yeah, too much amniotic fluid. Oligohydramnios is whenever the uterus is not big enough and it actually physically squeezes the embryo, and then as a result, the embryo actually gets malformed as they try to develop. Now, in this situation, the Potter sequence is just what it looks like, the malformations, what they look like, the facial characteristics. Those same facial characteristics can happen if the person has the recessive form of polycystic kidney disease, and it causes, for whatever reason, the same physical malformations. Okay. Dominant form often presents there in the young adults, and then bleeding in the urine, and then worsening renal failure. Questions? Anything in polycystic kidney disease? Yeah, I'm surprised I don't have images on that. It's quite interesting to see them. They're just tons and tons. In fact, maybe he has images. Yeah, probably he's got images. There's a Potter sequence image. I don't see. There's polycystic kidneys, 12.4. 12.4. Just tons and tons and tons and tons of cysts. Yeah. All right. Any other questions on that first material there? Yeah, go ahead, Julian. Yes. Yeah, it's actually not. No, it's got functional nephrons still filtering, just anatomically not the right shape. Yeah, otherwise it'd be okay. Was there another question? I missed somebody else. Yeah, Courtney.
The picture of the Potter sequence.
Yeah.
It says that the polycystic kidney disease for the autosomal recessive presents in infants, but that child was a preemie, right? Are they ever born?
Yes.
Okay.
Yes.
So they can live with that.
They can get to a live birth. Yes. Okay. Yes. Any other questions in that first material? Acute renal failure is next, and darn it, if I just thought of something, I wish I would have brought that to you guys. There's a new name for it too, and I'm blanking on it. That's relatively important. They've switched the name of it, and the naming is mostly for better communication with patients. So acute renal failure it sounds pretty bad, right? I mean, it sounds like failure, right? It's over. It's all done. I need to curl up into a ball and
Injury. Acute kidney injury.
acute kidney injury. So they changed the renal to kidney because patients know what kidney means, and injury because it more accurately represents what's going on here, which is often there's a progressive or there's quite a spectrum of damage that can be done. It could be horrible, but it could also be more mild in its magnitude. You probably should remember from physiology, azotemia, right? The urine, the nitrogen products in the blood not being filtered out. And creatinine, did I say that right? I was trying to double check myself here. I was about to say creatine. Nope, not creatine. Creatinine. Long pause there. Make sure you get it right. Also accumulating in the blood, as we know that it's normally filtered out. And if the kidneys aren't filtering it for one reason or another, then it's going to be accumulating. And then our three causes, which we briefly, if you remember, we briefly touched on these in phys. Pre-renal, post-renal, and then acute tubular necrosis there. Right? Pre-renal, I've got decreased blood flow. I'll summarize them. Decreased blood flow. Post-renal, I've got an obstruction downstream. Acute tubular necrosis, I've done something that has caused my renal tubules, my nephrons, those cells to be injured or die. And then as a result, now I can't filter properly, can't reabsorb properly, perhaps more accurately. Okay, let's just dive in. Any questions in any of those three right there? Any of those parts? Pre-renal azotemia, post-renal. One thing I would point your attention to that I wouldn't miss as I was reviewing this material in the future for the next exam would be the BUN creatinine ratio. That is huge. Being able to accurately match the ratio with the potential causes. Okay, so make sure you look at each of those. And notice it's a little tricky. Post-renal azotemia, it kind of depends if it's an early stage of obstruction or a late stage of obstruction of where that ratio is at. So don't miss that. It's a little bit tricky there. So, okay, any questions that you guys have on any of that? Well, let's see. Trying to think if there's anything else that I need to make sure I add to you guys. I have a ton of images, but most of the images are basic physiology images to use to explain concepts that hopefully are still relatively clear in your mind. Concepts like clearance of substances through the kidneys, the very basic definitions of tubular filtration, reabsorption, and secretion, those sorts of things like that. What else could I give you guys there? Yeah, question. Yes, Jillian. Thank you for saving me.
Explain the pre-renal azotemia.
What
is azotemia?
Yeah, so azotemia just means that I have, in the breaking down the word, azotemia means nitrogen in the blood. That's all it means. So if someone has azotemia, the only thing we know about them is that they got nitrogen metabolic waste products floating in their bloodstream. Usually always happens with something wrong with not being able to filter the blood adequately. So something in that whole process. Pre-renal means that I am not sending enough blood flow to the kidneys. So the classic example as they give there is maybe cardiac failure and can't push enough blood out to the kidneys. And then if we don't have enough blood pressure in the kidneys, that means we can't filter enough because we know filtration is dependent upon that pressure coming in. And then subsequently, nitrogen products will begin to build up as they can't be filtered out. Yeah. And then the ratio's high, right? The BUN to creatinine ratio is high there. That was a trick thing with physiology. I remember why that was a little bit high. What was the unique thing about? Go ahead. Yeah.
Well, I was gonna also ask.
Yeah.
So with pre-renal azotemia,
Yeah.
the reason why the BUN creatinine is high
Yes.
is because the nitrogen is easily reabsorbed while the creatinine is not.
That's it. He just said, I don't know if everybody caught that or not, but basically the BUN has some reabsorption that occurs. And if you guys remember, there's a glomerular tubular balance. Probably many of you have tried to purge that from your mind and like burn those neurons out, right? Glomerular tubular balance, which basically means that proportionally it increase reabsorption in situations where you have low blood flow to the kidney. Normally you would think with low blood flow to the kidney, well, maybe this person is low in volume. Maybe. And the kidney's natural response is that they kind of increase their absorption. They increase reabsorption. They pull back more fluid. Along with that, they pull back more solutes, more sodium, more BUN. The creatinine is not reabsorbed at all, and so hence it's unaffected by that. So it's still just lost at the same rate. Yeah. Does that,
So
yeah, question, follow up, and then back to Jillian.
okay, so the ratio is greater than 15.
Yep.
But with the post-basal azotemia, it's also greater than 15, but technically it's decreasing. Is that, or like if the ratio is, I guess, going away, and that's why
Right.
to the acute tubular necrosis, that's why it's less than 15.
Yeah, just reason through that for a moment. You just said that the reason the ratio goes high is because of reabsorption. If you have acute tubular necrosis, you destroy the cells, you can't reabsorb anymore. So the ratio goes back below 15 over time because of reabsorption can't occur. So you can't get the extra BUN that you had been has been saved from the kidney prior. Yeah. And then Jillian, and then up here. Yeah, go ahead, Jillian.
I'm just gonna ask, so the BUN creatinine ratio, I guess the high amount of BUN, does that do damage, or is that just a marker of saying, oh, your kidney's not functioning properly?
Yeah. So we only really care about the ratio whenever both levels are high. When both levels are high, that means something's not working right when it comes to filtration. We can't either get the fluid to the kidneys can't filter the fluid, or there's a blockage on the way out. The ratio between the two helps us figure out which of those three might be the most likely cause. That's where this comes in. The ratio, we don't care about the ratio in a healthy individual. I mean, we do a little bit, but in general, we only care about it once both of them are elevated.
Does the elevated amount of nitrogen, does that do damage?
Yes, well, it's due to your. Sorry, sometimes I forget to say the very bottom line here. These products are produced as metabolic waste products of metabolism from your cells, constant levels being secreted by your cells. So they're throwing it into the interstitial fluid, getting into the blood. Normally, your kidney excretes exactly equal amounts every day. If you do anything to mess up the amount the kidney's excreting, it just begins to build up in the body because it's a natural metabolic byproduct. That's where it's coming from. It's coming from normal cells just doing their business, but now there's no way to get rid of it, or it's not as effective a way to get rid of it. Yeah.
I was just wondering, since this is a renal disorder,
Yeah.
do they ever check the urine bun and creatinine, or mostly just serum because they're worried about acidosis?
You know, the serum matters the most because that's what tells you of how well the kidneys are truly functioning. In fact, we can take the creatinine levels and do some very simple math, and if you recall, estimate the GFR, which GFR is the ultimate way of describing kidney function. The urine levels, I think, can vary quite a bit, and I'm not sure I've ever heard of them being measured there. At least it's not as important as this. I can't rule it out, I guess, but yeah. Go ahead.
What's that normal value for
GFR
GFR?
is usually about 120 mils per minute. And we have huge capacity. We've got a huge capacity. So it's 180 liters per day if someone's trying to do the math in their head here. 180 liters per day in the kidneys. If you divide those liters out into milliliters and all that, you'll get about 120 mils per minute. We've got lots of reserve. A person will never know they have kidney problems until they have dropped down a long ways. In fact, I'm trying to remember the threshold, but I'm going to guess it's like 40 mils a minute or something like that is when, if you go below that, then you start to have problems. Yes?
The patient is at the early stages of post-renal leukemia. How do you differentiate that from pre?
Yeah, it's a good question. So one thing is, nothing is in isolation here. So you would be doing a good history on the patient to know what other comorbidities they had. You could also do direct tests, and you would know what their blood pressure is. You would know, let me try to think here about if there was an obstruction of the outflow, that's often going to present with pain. You're going to have pain coming from the kidney, which would not necessarily be showing with a pre-renal isotemia. I'm trying to think of all the differentials. This is good stuff. Differentials will be what you do a lot in ClinMed next year, but those are a few of the things that come to my mind. Yeah, you'd need more information than what's given in your path here. Without a doubt. You'd need some more to figure that out. Yeah. Good questions. You guys just need to warm up. You guys have some really good questions. I thought we were going to close the class for a second there. Yeah, go ahead. Yes.
No, we don't have to close class. But,
Yes.
Going back to the polycystic kidney disease.
Oh, sure.
Real quick.
Oh, finally got caught up on the reading in the last 5 minutes. I like that. Yes. Go ahead. Please, go ahead.
I haven't watched the video, I just had to read. So, with autosomal dominant,
Yes.
the Berry aneurysms, it says it's associated with Berry aneurysms and
Right.
hypocystic mitral valve collapse. Is the Berry aneurysms the ones that are in Michael Willis?
Yep.
Okay.
Same ones. Those little ones that are potentially going to rupture, cause a brain bleed.
Is that prior to rupture or just during the formation or development of it?
Well, by definition, a Berry aneurysm is just the outpouching. And these individuals genetically are more susceptible to those than an average individual. It's a problem that happens with polycystic kidney disease because of the mutations involved also weaken the walls of the arteries. Just like the kidneys now get these cysts because of basically wall problems, so did this up here. Not necessarily a direct connection there, other than the underlying genetic cause.
That makes sense.
Yeah. Good question, though. Yeah. Okay. Before we go too much further, we better get into something important. That is nephrotic syndrome. I'm going to go ahead and jump towards there. If you have any questions on the interstitial nephritis, papillary necrosis, we can come back to that. But let's go to nephrotic syndrome. Whole category of diseases. And here's the key thing you've got to burn into your mind, and that is nephrotic diseases are defined as a group of kidney problems where you get protein in the urine, high levels of protein in the urine. Okay? Now, the bad thing about these categorizations, I have to admit, is that we've got nephrotic syndromes, which are protein in the urine, and then we got nephritic syndromes, which we'll do next class period, which is characterized by inflammation happening in the kidneys. Now, here's the bad thing about these. They are not mutually exclusive, okay, in the sense that you could have a disease that both has some inflammation and it's got protein in the urine, and it's kind of pretty arbitrary of where we categorize the disease. So be aware of a blurry line between nephrotic and nephritic syndromes. Just a heads up on that. Not only do they sound alike, but they're actually, the categorization comes pretty close to each other. So protein in the urine, high levels here, we're losing that. Going to cause pitting edema. That makes sense because we lose protein out of the bloodstream. We know that edema is going to result from that. Lose antibodies, hypogammaglobulinemia. Say that 3 times fast. So you're going to increase risk of infections, hypercoagulable because you're losing antithrombin, and then hyperlipidemia, hypercholesterolemia. Both of those are kind of responses of the liver to what's going on because it's trying to upregulate the protein that's being lost, but actually on the side it's going to upregulate the lipids as well. Those high lipids can result in having fatty casts in the urine. And I think I even described casts to you in physiology. Does anybody remember a cast? Tell me, what is a cast? I saw Ashley nod her head. Oh, see, you should nod your head. Do you remember?
I know what they look like.
Oh, okay. She's actually seen them. Okay. What do they look like?
They're like oval,
Tell me if I'm wrong here, but would this...
rounded.
You kind of put little rounded edges on them. Okay, I see. See if I can get my drawing right around there. Okay, is that better? Okay, that passes the test. Now the question is, why do they look that way? Shannon. That's it. Remember a cast? We think of like a mold that maybe a sculptor makes a cast of a bronze thing, and they're gonna create this sculpture. Well, they make the cast first, and then they pour in the stuff, and then the statue forms in the shape of the cast. The renal tubules are the casting mechanism, and we're putting stuff in there that shouldn't be in there, and it takes the form of a tubule, and then the tubule makes it look just like that. So keep that in mind. We've got lots of casts. In the next several diseases, all kinds of casts, and they're just based on the renal tubules. Okay. Now, yes, question, yeah.
Do you use the cast to determine if you have, if just red blood cells are leaking through the glomerulus?
Yep.
And then differentiating that between
Yes.
bleeding of like downstream?
That's exactly it. You just said something very important. I don't know if everybody caught that. We'll get into that probably in the next class period, but yes, the change in bleeding, you can tell. If it's from the kidney, it's going to be casts, or if it's in the tubule system. If it's downstream of there, it just is normal red blood cells that end up in the urine. Mm-hmm. Maybe they got a urinary tract infection or something else that's causing some bleeding. In the nephrotic syndrome, one thing that I should show you a picture of, and that is a couple of these diseases are caused by deposition of immune complexes. So first off, let's take an image right here. And what you're seeing is the orange here this is a capillary. This is the inside of a glomerular capillary. The endothelial nucleus is this purple part right there. And then around, do you guys remember what is this, these little fingers here? Or maybe to be more accurate, the little feet? The podocytes, right? So the podocytes, they wrap around and they help form the filtration barrier, okay? What this image shows is that the little Y-shaped things are antibodies. And if you remember, one thing that can go really bad is you can have immune complex deposition. You may remember anything from lupus? What was one of the nasty things that could happen from lupus with your kidneys? Straight up renal failure, right? What caused that? Deposition of antibody antigen complexes, which means, I don't know if you see this on the image, all of these antibodies, and they're kind of blurry, I apologize, they're all Y-shaped, and they're all binding their target antigen. Wow, that's hard to see. Goodness sakes alive. Choose another color we can actually see here. They're all binding a little antigen. This happens somewhere else in the circulation. So I've got lupus, I've got antibodies to DNA, that's circulating around. It finds a little chunk of DNA, it binds the DNA. Now that antigen-antibody complex is floating around, it ends up in my kidneys, it lodges in the filtration barrier, and then once it's stuck there, what happens? Inflammation and damage, right? Inflammation happens because anytime you got antibodies that have bound their target, they're like little signals for the immune system, attack here, there's something wrong here. And so the immune system does that. And then now, of course, you get damage to the filtration barrier and potentially end up with nephrotic syndrome because protein now can spill right through the barrier because you got open holes within the barrier that you shouldn't have. Now, there's also antibodies that circulate around that can come in and bind to antigens within the membrane. So, for example, maybe you have autoantibodies that they're actually specific to the proteins in the filtration barrier. And so they'll come in and get stuck to the filtration barrier, creating a very similar situation. Okay? And that's essentially the last couple there on the right-hand side. Questions? Yes?
To prevent it from going to chronic renal failure, since they don't respond well to steroids, would you just suppress the immune system with some other mean or remove the spleen if you need to?
Right. Well, unfortunately, there's a reason why in many of these they do not list a nice other treatment. There's not another good treatment. Yeah. Some of these diseases, it is a progressive, slow march towards renal failure, which is really unfortunate. Highlights the importance of kidney transplants, highlights the importance of, that sort of thing, but not that I know of. Maybe there's up and coming new awesome things that are coming out, but not that I know of. Another capstone potential idea there. There is good treatments out there. There are new things that'd be worth noting. Okay, any other questions on anything here, nephrotic syndrome? I know we didn't get into the specific diseases, but I'm happy to clarify any if you did have questions on that. What we can do is, once you've taken a look at that, you can bring those questions to class next class period, and we can address them together with the nephritic syndromes and make sure we get all the questions answered. All right, have a good rest of your day, guys, and we'll go from there.